I am happy, very happy, to introduce Jill Steiner. So Jill is currently our adult congenital heart disease fellow, but is also working on a T32 grant through palliative care. Her trajectory towards doing what she's doing has been a less wandering road than many. She did her undergraduate work at Penn State, who have been back on the football game recently, and so she's been a much happier Penn State grad than she had been a number of years ago, where she did a biobehavioral health major and also minored in Spanish. So then she went off to Georgetown for medicine residency. She was a chief resident, came here for general cardiology, and when she came here, she specifically had an interest in adult congenital heart disease, having been fostered by one of the more senior members of the ACHD community at Penn State. So when she came here, it was with the intent that she do ACHD, and lo and behold, now she's doing adult congenital heart disease. But she also had this background interest in sort of the biobehavioral health, and through that has linked ACHD with palliative care and a lot of the psychosocial issues that these patients face. So what she's going to talk to us about today are some of the psychosocial issues of ACHD patients, and for everybody who's taking care of them on the inpatient service, this would seem to be the dominant feature of their clinical presentation. So she's going to talk with us some about that, but she'll also touch on some of the research she's been doing. And the cool thing about the research she's been doing and her interests is that she's already garnering national attention for this over the last couple of years, because it's so unique, and because she does such an incredibly good job of it, and because it really is a needed thing. So with that, I will let Jill, whom we are absolutely delighted to have continue with us going forward, come up here and give us a talk on the psychosocial concerns of the care of adults with congenital heart disease. Jill.
Okay, I was told to put this on, so I will do that. All right. Good morning, and thank you for this opportunity. I'd like to speak with you today, as Dr. Stout said, about some of the psychosocial concerns in the care of adults with congenital heart disease. I have no disclosures. I'll start with a case. Barry. Barry's a 31-year-old man with tetralogy of Fallot. This was repaired as a child, and the repair consisted of a VSD closure and a pulmonary angioplasty. He's never had any adult congenital heart disease care, and he was last seen by his pediatric cardiologist in his early teen years. He was referred to the University of Washington for 9 months of progressive dyspnea on exertion and palpitations after recently establishing care with a primary care physician. Not surprisingly, and as you can see by this image, Barry's found to have severe pulmonary insufficiency with RV enlargement. This is a summary of Barry's encounters. Like most people, it took a few tries to get Barry on the phone and schedule his first appointment. But then he was late, and he had to be squeezed in for his echo after his clinic visit, which limited the conversation during his clinic visit. Then he was a no-show for his CPET. We wanted to bring him back to discuss possible treatment pathways and get to know him a little bit better. But as you can see, he canceled that appointment, eventually rescheduled it, canceled it again, rescheduled it again, and ultimately no-showed. You had this thought, right? I have. Maybe because we see things like this pretty frequently, there is just this general feeling that patients with ACHD are difficult. It's not just because of their anatomy. Now, Barry isn't real, but Barry represents a conglomeration of a lot of patients with ACHD who are kind of hard to care for. Before I go any further, I should say that the majority of adults with congenital heart disease do not fall into this category. Most of them are milling about, doing their thing, achieving cool stuff. But patients like Barry struggle with more than their share of psychosocial and neurological issues that can hinder their care. So I'd like to spend the next 30 minutes or so talking about these neurodevelopmental and psychological issues and how they compromise care, and then what we can do about them. And this is important for everyone, whether you encounter one of these patients on the inpatient service, here in the inpatient outpatient service, quaternary center, or out in the community. There are 1.5 million adults with congenital heart disease in the United States, more adults than kids. And that's not a lot compared to other chronic illnesses, But it's a substantial and growing community that is recognized to have some unique needs. When the struggle was simply, not simply, but you know what I mean, to get kids with congenital heart disease just to live, a lot of these neuropsychosocial issues were overlooked. But now that more than 90% of those kids are making it to adulthood, things like quality of life and independence are a lot more important and more central to the care of this patient group. Only 1 in 3 patients with ACHD receive the recommended level of care. It's not uncommon for there to be a significant lapse in care after the pediatric years. This usually occurs around age 20 as patients go out on their own, fall off their parents' health insurance, and about 10% have gaps that are longer than 10 years. The patients with mild disease are twice as likely to have one of these gaps, which makes sense because they're probably are the ones not dealing with other comorbidities. But this becomes a huge problem when any of them show up years later with advanced disease that could have been prevented or at least proactively managed. At best, this inconsistent care is because the patient feels fine and they had no idea they needed follow-up. Many are under the impression they're cured. There are not enough adult congenital heart disease providers to see everyone, and when they exist, their practices are usually far away from where patients live, in a city that requires at least a day of travel, a day off of work, and a lot of stress about time, traffic, or money. But other, worse reasons for inconsistent care are because of gaps in providers' knowledge or misperceptions that can lead to dangerous patient encounters. Every ACHD patient can probably tell you about at least one time when they had to explain their heart to an ER physician, like the patient I saw last week who had to spend some time convincing that person that her MVR was actually a mechanical tricuspid systemic AV valve. Some have been lucky that they didn't end up with a stroke from an IV line that nobody thought to put a filter on. And others, unfortunately, were phlebotomized to the point of severe hypoxia and sludging that did cause neurologic events. Now, none of this is done maliciously, but it adds up to frustration with the medical system, which is in addition to normal frustrations with the medical system, like wait times and frustrating communication. And for those patients who feel limited by their congenital heart disease, living with a disability that's not easy to see has a similar effect as a language barrier. Your care might be based on less than the whole story. And while that certainly holds for ACHD anatomy and physiology, it absolutely holds for any cognitive impairment or psychologic disease that hasn't been noticed because it doesn't come with a sternotomy scar. That too can be frustrating, isolating, and dangerous. Many patients with the same anatomy can have widely varied clinical experiences, and we know that patients' subjective perception of disease does not always correlate with objective data. 3 patients with the same Fontan repair for the same single ventricle disease I've seen recently have completely different lives. One was a grad student across the country, checking in with her ACHD team occasionally, but otherwise thinking nothing of it. The second was working locally, feeling fine, hoping to become pregnant, but her CPET showed an alarmingly abnormal exercise capacity. And the third was at home, on disability, cyanotic, and struggling with a terrible quality of life. So we're really well trained to look for, manage, and deal with a lot of these physical problems. But we're really not good at looking for and managing cognitive and psychosocial problems that can be equally difficult barriers to care. And so that's the reason why I chose this topic. Looking to bring some attention to the existence of these issues and to talk about what we can do with them. So I'll start with some neurodevelopmental ones. Children with congenital heart disease are known to be at elevated risk of developmental disorders and disabilities, as well as deficits in executive function. These are usually most common in patients with severe or syndromic disease, but they can exist at all levels of lesion severity. For most part, these challenges do not disappear in adulthood, and they can actually become more prominent in the less structured adult environment. The most obvious impairments usually show up in patients with syndromes, many of which are also linked to the existence of their congenital heart disease. 18% of congenital heart disease lesions are associated with genetic conditions. The most common syndromes that we see in adults with both cardiac and cognitive consequences are Down syndrome, DiGeorge syndrome, Turner and Noonan syndrome, and Williams syndrome. Some of the cognitive impairment related to these syndromes is evident in childhood. But for many of these patients, their phenotype's on a spectrum, and they may not be. There's also the risk of adult onset cognitive diseases, which can occur more likely in conjunction with these syndromes, like Alzheimer's disease or Parkinson's disease. And then things that happen later in life, like arrhythmias or heart failure, can also contribute to cognitive impairment. So can we rely on genetic testing to help identify patients with cognitive impairment? Well, no. Most adults haven't been tested. You know, it's expensive, and if no lesion was obvious or no deficit was obvious that made someone think to do it, it probably didn't happen. For the last 10 to 15 years, most kids with conotruncal and some other defects end up with FISH sequencing. But that's just in the last 10 to 15 years. And that doesn't encompass most of the patients that we see. And yet there's this big misperception that someone had to have already checked if this patient's been in care their whole lives. We just aren't trained, again, to look for things unless we suspect something. And in the adult realm, this doesn't really come up unless we're discussing family planning. Beyond that, not all genetic abnormalities can be identified by the current tests that we have, even if we thought to do them. And finally, not all deficits are related to genetic abnormalities in the first place. Many things can influence cognitive outcomes, aside from severity of the congenital heart disease lesion. Some of these are patient-related, physical things, like prematurity, prior cardiac arrest or seizures. But also things like socioeconomic status can have a huge impact on development. And then other predictors have to do with prior procedures or surgeries or prior hospital stays. And since many of these predictors happen early in life and concurrently, it can be really hard to tease apart their effects. Now, cognitive testing doesn't necessarily reveal the cause of impairment, but it can quantify it. This group of school-aged patients with hypoplastic left heart syndrome had lower than normal performance in a number of neurocognitive tests. The expected population mean score for these is about 100, and you can see that most of their scores fall below that level, even though the average mean IQ in total was within the normal range. And 1/3 of children in this group required some form of special education. Social and behavioral problems are also more common in kids with congenital heart disease, either with or without severe neurologic disease, which is groups A and B in this table, following neonatal surgery compared to normal controls. The congenital heart disease group here had more social and attention problems, more difficulty internalizing and externalizing these problems, and all of this affected school performance. A lot of this work has been done in school-aged kids because of the things like tracking childhood milestones and development and school performance. And once you're 18, there's much less of a tendency to help and more of an idea that you should have figured it out by now, which makes absolutely no sense, because why would the kid who needed help on a daily basis as a kid suddenly not need special services anymore just because they're 18? Nobody thinks about that. I said on an earlier slide that there are a number of surgical considerations that can also influence cognition. And so what is it about surgery? Of course, there are correlations to the timing, type, and length of the surgery, but also type of support used during surgery plays a huge role. Cardiopulmonary bypass and total circulatory arrest are both associated with increased risk of neurodevelopmental vulnerabilities. With newer technology, this is less so than in the past, but it is still a concern. Some of these manifestations include worse motor, visual, spatial, and language skills, memory, hypothesis generation and testing, and attention, all of which, again, can limit academic achievement. Worse planning and impulsive behavior have been shown to be more correlated to bypass, and circ arrest is thought to specifically affect motor function, with worse deficits overall than those associated with bypass. In the 90s, work was done to establish this relationship. You can see in these images the relationship between increased length of circ arrest and a higher probability of neurologic abnormality and lower psychomotor development indices. Deficits were worse with longer arrest duration, independent of congenital heart disease diagnosis. While this work brought awareness of the relationship, a universal cutoff for a safe circ arrest time has not been established. More research revealed a nonlinear effect of arrest time on neurodevelopmental outcomes, with significantly worse impairments in multiple areas after 41 minutes. And so, an effort is made to make the amount of time in circ arrest as short as possible. Easier said than done when you're trying to do something like a Fontan conversion. The last thing I want to mention in this category is related to cerebrovascular pathology. Strokes are not uncommonly seen, sometimes occurring in childhood, but also later in life, due to embolic disease and erythrocytosis in cyanotic patients. Vasculopathy, we know, can coexist with congenital heart disease, and ruptured aneurysms can lead to impairment or devastation. As can cerebral abscesses, which are of high concern for patients with right to left shunts, and these can also severely affect cognition. Next, I'd like to move on to some of the pertinent psychological issues that we face in this group. Living with any chronic disease can put a lot of pressure on the psyche, and congenital heart disease is no different. Many factors have been identified as adversely impacting mental health in this group. Negative body issues over things like scars and feelings of inadequacy that lead to low self-esteem are prominent. Peer relationships might be impaired because of missed school, long isolating hospitalizations as a child, or limitations to physical activity that prevented kids from participating in team sports. When present, obviously disrupted family dynamics can be stressful, and parental overprotection really hinders the development of autonomy as these kids become adults. In one study, the maternal perception of the patient's health, accurate or not, was what most closely related to maladjustment, more so than even the severity of the underlying medical illness. Feeling different, and perhaps worse, feeling perceived as different, is another factor impacting mental health, and so is denial of impact of the medical condition. This is an interesting defense mechanism where patients downplay the consequences of their illness and rate their health higher than objective data would suggest. We know this is present in adults with congenital heart disease, and it's thought to be related to patients being accustomed to hearing negative health information. This type of denial has actually been shown to be associated with less anxiety and depression, which sounds great, but an incorrect perception of one's own health and the other factors I've just mentioned can all lead to maladaptive coping strategies and medical non-adherence. We touched on behavioral issues in kids a little while ago as they related to surgery, and now I'll point out some other psychosocial limitations. Compared to adults without congenital heart disease, those with, in this group, have been shown to have lower scores for independence, problem solving, and self-esteem on psychosocial testing. They also had higher dependence on their parents. In another study by this group, these issues were better in a group of adults with congenital heart disease who were in their 30s compared to one who was in their 20s, but there was more anxiety in that group, and there was more of a negative perception regarding their congenital heart disease. Mood and anxiety disorders are very common. In a study of patients without known emotional or behavioral difficulties or symptoms, more than a third of those patients were found to have a diagnosable psychiatric disorder during targeted screening, with anxiety and depression symptoms up front. Another 27% had scores indicating pathological emotional functioning, and those didn't quite meet the cutoff for diagnosable disease, but they were certainly enough to influence the way they felt about themselves and took care of themselves. In their study, there was significant association between the patient's medical severity scores and the occurrence of mood and anxiety disorders, but that's not always the case. Now, that was in a study of patients without symptoms. In this one, which was a study of consecutive patients in the ACHD clinic, 50% of patients had experienced a mood or anxiety disorder at some point during their lives. 1/3 fell into the categories of major depressive disorder or dysthymia, and another 25% were experiencing anxiety disorders like panic disorder, phobia, obsessive compulsive disease, or generalized anxiety. And yet almost 40% of them had never received any mental health treatment, revealing a significant under-recognition and under-treatment of disease. This study went on to identify some determinants of symptoms of depression and anxiety. You know, even if we think to ask about the presence of anxiety or depression symptoms, we rarely think about what influences those things or is underneath their development. In this study, disease severity and NYHA functional class were not predictive of symptoms. However, poor perceived health status was found to be a predictor of depression, and loneliness and fear of negative health evaluation were found to be predictors of both anxiety and depression. The impact of perceived health status is very powerful, particularly as it relates to quality of life. Other studies have shown poor quality of life to be associated with depression, of course, but also with alcohol and nicotine dependency, going back to the maladaptive coping strategies I mentioned earlier. That thought segues into this study done in England, which identified all ACHD patients in their care treated with antidepressant drugs. It did not evaluate who met criteria for treatment, only who was on treatment. And that was only 3% of their total group of patients. The use of antidepressant drug therapy in ACHD was associated with increasing age and disease complexity, and also sex. Twice as many females were on antidepressant drugs as males, but it was the males who were at increased mortality risk. A little bit hard to see, but the figure on the left suggests the difference in survival between patients on ADDs compared to those who aren't, and more so when this is broken up into males and females. The figure on the right, which was created after accounting for baseline differences in the groups using propensity score matching, looks at the overall difference, and here that was not significant, but when it was broken down by sex, males on antidepressant drugs still had significantly worse survival compared to patients on no drugs at all. Why that's the case is not known, but males in this study on ADDs did have worse adherence to scheduled clinic appointments, which perhaps allows us to identify people in that situation as at higher risk for adverse outcomes. And in case you were wondering, there was no evidence that that excess mortality was related to the drug itself, like QT prolongation or malignant arrhythmia. I'll switch to PTSD, which is another under-recognized psychologic issue. In cardiac patients overall, this is known to have an association with adverse outcomes and increased mortality. In this study of outpatients with ACHD in clinic, 21% had PTSD symptoms, and 11% of patients met criteria for PTSD specifically related to their congenital heart disease or its treatment. Those patients were more likely to have had cardiac surgery at an earlier age, higher rates of stroke or TIA, more depressive symptoms, and they were less likely to have attended college. In multivariable analysis, the two factors most strongly associated with PTSD were depressive symptoms and the year of the most recent cardiac surgery. Interestingly, congenital heart disease complexity was not associated with PTSD, nor was the total number of procedures. Not investigated in this study, but a topic of anecdotal importance and potentially future study, is the type of anesthesia used during procedures, as patients have reported more traumatizing experiences when things like ketamine or brandy were used as sedatives. Now, after going through the neurodevelopmental and psychological issues pertinent to this patient group, I'd like to pause and return to Barry for a moment. What if, at that first visit, we learned that Barry thought he was cured, and he didn't know he needed any follow-up? What if we also learned that Barry was on treatment for ADHD as a kid, and that since being out on his own, he's had a really hard time holding down a job? That's been stressful on him, and it certainly impacts his ability to have adequate health insurance, which he's even more freaked out about now that he thinks he might need another heart surgery. And what if, as part of that visit, we had screened him for anxiety and learned that he meets criteria for generalized anxiety disorder? Would any of these things make you think about him in a different way? The good news is that there are some things we can do, and I'll spend the rest of this time discussing some strategies for improving care. The three major strategies I'll cover are: 1, an adequate transition from pediatric to adult care; 2, the availability of a variety of services made possible by the existence of a strong multidisciplinary team; and 3, not necessarily end of life, but certainly advanced care planning. The transition from pediatric to adult care is a time of great importance. More and more research has shown that patients do better if this is a seamless, smooth, and formal process, because this isn't just a transfer. While at some point, being an adult admitted to the pediatric hospital becomes uncomfortable for everybody, the switching from a pediatric environment to an adult system of medical care is not easy, and it's not just because the hallways look different. Patients report an experience that looks a little bit more like these bunnies. Thank you, Dr. Stout. Which of course is a reference to this amazing scene. They go from a place where everybody knows them and they're comfortable and their needs are cared for, to one where they're kind of on their own, and it's scary there. And transition is a total change of mentality. For the first time, patients need to take responsibility for their own care, and they need to learn to advocate for themselves. This involves negotiating independence and developing mature relationships with their caregivers. The job of parents, and both pediatric and adult providers, is to foster that development by providing the necessary information and support for that child to learn without being overprotective. And this can only happen if care is given at a level that is developmentally appropriate for the patient. This process is suggested to begin around age 12, assuming developmental and physical age roughly match. Self-advocacy begins with resolving any lack of knowledge or misperceptions that that patient might have about their heart disease. Information should be individualized for not only that person's maturity level, but also their prior experience with medical decision making. And remember, most people don't have experience in this at this point in their lives. Educational material should be provided in multiple forms, electronically and on paper, and it is recommended that we give a medical passport of information to patients detailing their history so that they can reference it in the future. The goals of the transition are as you might expect. This publication by Amy Verstappen, who not only leads the Adult Congenital Heart Association, but is an ACHD patient herself, proposes the following. 1, solicit and respect the patient's point of view in order to support developing autonomy. 2, use education to support lifelong self-advocacy and self-care. Assess function, both physical and emotional, through serial testing, and provide resources for mental health and peer support when they're needed. This is all part of the process of planning for the future, which is the last thing listed here, and one that I'll come back to in just a few minutes. The second care improvement strategy is building a strong multidisciplinary care team, which can help the patient navigate the adult medical environment. The team not only includes at least one ACHD clinician, but also a dedicated ACHD nurse coordinator, surgeon, and social worker. Ideally more than one. Multiple guidelines also recommend the inclusion of a psychologist or psychiatrist to help address some of the psychological concerns that we discussed today. And it's also really important to establish partnerships with other medical subspecialty teams. Teams like nephrology, hepatology, and palliative care, importantly, who are familiar and comfortable treating ACHD, can provide the necessary non-cardiac care that these patients frequently need. Patients definitely don't want to, and absolutely shouldn't have to, explain their heart disease to other members of their care team. Screening is an important thing that the ACHD team is tasked with providing, and that is screening of the individual, and when appropriate, the family, to assess knowledge of cardiac disease and its management, their perceptions about health and the impact of their heart disease on it, whether there's any difficulty with social functioning, employment, or insurability, and to look for the existence of any cognitive, mood, or psychiatric disorders. Another responsibility of the care team is to provide lifestyle counseling regarding things like whether there are restrictions to exercise or physical activity. Conversations around tattoos and piercings center not on social acceptability, but on risk of endocarditis. The use of alcohol and substances like marijuana may have nuances particular to ACHD, like the patient with Fontan-associated liver disease. And contraception and family planning are big topics that play a huge role in the patient who's just trying to lead a normal and fulfilling life. There's not a lot of evidence to back strong recommendations for any of these things in the ACHD population as a whole. And yet that's another reason why members of the multidisciplinary team should have experience working specifically with this group. The last team-specific service I'll mention is assistance with job finding and training, and with obtaining and helping to keep life insurance. There are lots of resources at the state and national level for vocational assistance, but it takes someone on the team to connect the patient to them, and that's usually a social worker. Many patients with ACHD who are unemployed do have the potential for meaningful employment if a job that is appropriate for their physical, mental, and emotional abilities is identified. Now, this is obviously tied to that patient's ability to have health insurance, which we know impacts the ability of patients to pursue consistent medical care. And life insurance can be really hard for any patient with anything to get, never mind someone with severe congenital heart disease. Like employment, a big part of the insurance difficulty is lack of ACHD-specific knowledge. And so it is important for the clinicians on this team to provide insurance companies with the latest information that's relevant to this group. The final topic I'd like to cover under strategies for improved care is planning for the future, particularly the importance of early advanced care planning. Long-term survival is an expectation for most people with ACHD. As I said, it's not uncommon for patients to hold the misperception that they've been cured or at least fixed by their prior interventions. Their transition into the adult medical community may be the first time that they're confronted with their own mortality in a way that is meaningful to them. In childhood and adolescence, these conversations are typically held with the parents, and the child, now the adult, was either not present or doesn't remember those. And that's not an option anymore. It's our job to help balance hope with realism, and so discussions about life expectancy and the future, whatever that means, are an important part of the general conversation surrounding psychosocial health. The notion of a life cut short is understandably distressing for patients, their families, and their healthcare providers. Although it's often difficult for us to initiate care planning discussions, they need to happen. Like other information that's provided to patients, discussions must be conducted in a manner that's appropriate for their level, and care preferences should be delineated as they come up. As they're delineated, they should be documented, ideally in a legal document. But even a non-legal document is helpful to the parent or friend that has to step into the role of medical decision maker for that patient. And to help prevent this from happening unexpectedly, patients should be urged to identify a designated healthcare power of attorney. This is especially important for those patients whose intellectual or psychosocial impairments may leave them unable to comprehend risk or provide adequate informed consent. The good news is that for the most part, patients want to have these conversations. In a study that we're working on, 79% of participants in the outpatient setting were at least moderately willing to have a discussion with one of their doctors to discuss care preferences. 69% were willing to participate in advanced care planning activities. And 91% were willing to speak with a palliative care specialist if their ACHD doctor thought it was a good idea. When to begin these conversations, however, remains nebulous. It's difficult because patients with ACHD are younger than most patients with life-limiting illness. And in contrast to patients who have had a heart attack as their first medical problem at age 60, these patients may not have a signal event until late in the decline of their health. In one study of ACHD outpatients, the majority of patients wanted their doctor to initiate these discussions. They felt weird bringing it up ahead of time, and that was reflected in our study as well. And most patients preferred for these conversations to begin while they were feeling fine, before they were faced with difficult decisions, and certainly before they developed any symptoms. So even though these conversations are not easy, we should initiate them and invite them early. And the last thing I'll say about that is that wishes can change. We know that. They do change often. And so we should revisit these conversations frequently, and certainly during times of emotional or mental stress, certainly during times of physical stress, or at a change in the clinical status. And so I hope I've convinced you that difficult patients that you see with ACHD may be that way for a reason. Maybe one you haven't thought of. Neurodevelopmental and mental health issues are common, and they need to be recognized in order to provide whole person care to these patients. And that is best done by facilitating a seamless transition from pediatric to adult care, building a strong multidisciplinary team with the resources to provide a multitude of services, and initiating early advanced care planning that is at the patient's level. We've got to meet them where they are. Thank you. Questions?
That was a fantastic talk, and I mean a lot of important issues. I guess the thing I always wonder is, why is this unique to heart disease? I mean, isn't this the same problem that every adolescent with any kind of chronic disease faces, whether they have diabetes, lung disease, arthritis, or heart disease? And perhaps you could build more effective systems for that transition and more effective support if all the different areas of that transition work together. Rather than having individual people for each different part organ of the body.
No, that's a really good point. I think we talk a lot about medical silos and how they can do great things, but they can also cause lapses in communication and isolate patients who are going through the same thing related to different aspects of their diseases. And so, yeah, I think you're right. I think it's important for people to talk to each other, and that's part of the inclusion of other subspecialty services in our care. And you're right, these issues aren't specific to cardiology. It's just that this is the room I'm talking to, and so, this is what we see. And I think having congenital heart disease, where maybe you've had 4 surgeries before age 25, is a little bit different than growing up with type 1 diabetes, because maybe you've spent time in the hospital, but maybe you haven't, and maybe you've had surgery for something, but maybe you haven't. But to your point overall, no, it's not specific to cardiology, and it is something that we should just do a little bit better on the whole.
And I think there are efforts out there to make a more just comprehensive transition program that is for all kids with complex health needs. And I think one of the reasons you see more of it, transplant has a huge investment in that, obviously. So if April goes over and sees the transplant kids from cardiac transplantation services to get them over here, because there's a tremendous resource investment in that patient population. But it turns out, because congenital heart disease is so common, and there's all these different iterations of things that Jill really nicely outlined that can influence them, that there's a huge amount of work done in cardiology that then has been used to spill out to other disciplines where they don't have quite the number of patients involved. But having uniform transition services is helpful and does happen quite a bit, but cardiology tends to lead the way, both for being common and for efforts like ours that have always been a joint pediatric and adult environment.
Yeah, of course, I mean, these people often have that organ system disease, and the other thing they had as a child was that somebody, coordinated that up for them, like a parent, like coordinated their GI and rheumatology and cardiology and pulmonary clinic appointments. And then in the adult world, we don't do that. And so again, that's why I kind of feel like doing this in our silos, doing this in cardiology, in terms of the resources and the system that works for patients. I mean, I don't think you really look at the patient point of view. The patient point of view would be not just my heart, but all of them, and have support systems to support that.
Yeah. Dr. Bryan?
That was really a great talk. I thought Catherine's question was going to be when you're going to submit the review article. This is thinking about it in a little bit different way. The way the population you have to deal with is very similar to all the populations we deal with cardiology here. That is to say, the very advanced, they have relatively complex advanced disease, but there's a larger population out there that have these conditions or illnesses. And so, how do we get out to them?
In terms of the rest of the ACHD world?
The rest of the ACHD population and the rest of the heart failure population. I mean, you could insert subspecialty here.
Yeah, I think a big part of that is, for anybody that's established in outpatient care, is just asking. You can ask 2 questions during your clinic visit. Have you felt in the last 2 weeks depressed, hopeless, anxious? Yes or no? And if the answer is yes, then there's other questions you can ask. And if the answer is no, then, maybe there's nothing there that day, but there might be next time. And so I think getting just the knowledge out to people to build this into their even primary care visits, which honestly, they're usually better at it than we are, but we just need to be better about consistently asking these questions.
I think there's the downstream effect that's been talked about a fair bit as well, is if you ask the questions, then what do you do about it? And having the adequacy of mental health evaluation, it doesn't take, more than 3 weeks in the United States before there's yet another mass shooting that demonstrates that we have absolutely no mental health infrastructure that is effective, even if you're touching a healthcare system frequently. So I think that one of the problems that people have identified is that we can ask the questions, but then what do we do with it? So I think Jill's point of involving primary care providers is huge. As to the awareness out there in the world, there's so many stigmata attached to some of the psychosocial issues to start with, that getting out public health information, just grabbing ACHD patients to get them back in care is super important. And one of the things I think that is from a teaching perspective that Jill mentioned is it doesn't correlate with the severity of disease, which is a funky thing. Some of the most psychologically kind of devastated by their heart disease patients that we take care of have closed ASDs with no residual. And yet somewhere in there they've been built up as, oh my God, this is a catastrophe. And so if you're basing your questioning on your perception of severity of disease, you're going to miss a big chunk of patients who are actually going to have issues. And I think that's true of heart failure, myocardial infarctions, the whole 9 yards. There's such a complex interplay of how people do. I don't know exactly how we grab everybody, but I do think that once you've asked the question, you also have to be prepared to figure out what you're going to do about it.
Yeah, I mean, this is the similar problem in a sense with psychosocial aspects of illness, compliance, depression, that we have a lot more resources here than people have in home area.
Yeah.
Right.
Sometimes, but sometimes patients still have to wait months if they ever get a psych appointment, or months. I mean, they can't even get a palliative care appointment. So I think that goes back to building a team that has resources to actually send your patients to once you identify the need for referral.
And it's remarkable how often people bring up just out of the clear blue sky. So how long should I expect to live?
I just want to say what you're saying, Kevin. You talk about the difference between our resources here and the community, but the biggest thing I have found is the difference in resources between children here in Nevada. And because of the payer situation, and because of the fundraising that children have, they have so much more robust social worker and psychiatric support for these patients. And then they transition to here and you have nothing compared to what they have there. So I'm wondering, have you found any data on that? Like nationwide, it's like, multidisciplinary seems better, but that multidisciplinary team that we put up, we don't have. Right?
And we should.
I mean, is there data that if you have that, all those 6 patients survive longer for the transition?
I didn't see anything in like a randomized trial format, but kind of observationally, yeah.
Observationally.
I'm not aware of it.
Because I know in heart transplant, the mortality of transplant patients after transition, they have done studies of patients that stay at pediatric hospitals versus patients that transition to adult hospitals. There tends to be a slight benefit to staying at pediatric versus transitioning. But
Although out of both renal transplant and liver transplant, there's little titches of signal that the transition time also happens at the worst time. So you get a bunch of 19, 20-year-old, we've all been there, complete idiots who are now having to actually take care of themselves. Let's all remember how college went for at least a day or two. And now you've got complex medications, anticoagulation, blah, 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 you're arranging your healthcare. So now you're asking a lot of them without infrastructure to do it. So you're kind of hitting them on the worst times. And in the renal and liver transplant arena, there's very small studies. They're like 10 to 12 patients. Mortality is higher in those patients for sure because they go off the rail on their meds. And we see that in patients with chronic anticoagulation. That the kind of 18 to 23, 24-year-olds can come in with strokes because they just decided, wasn't my choice, I'm not taking this anymore. Denise?
Yeah, I am always amazed that we do send them out at that age, the age when their frontal lobe does not work. And of course they go off to college too, and they're not set up with providers at those institutions. But I did want to clarify a few things about the anesthetics.
Yeah.
I've never used brandy to
Good.
We really don't use ketamine anymore.
Yeah.
There is, this, obviously anesthetics and neonatal and pediatric brains are a big topic now.
Yeah.
I think it's generally felt that less than 30% of neurological outcome could be explained by medication or even procedures, techniques of surgical procedures, bypass management. We rarely use, and circ arrest is rarely used anymore except for a couple of procedures. Mostly it's low flow, although, of course, as you said, there's probably some neurological, low flow is low flow. It's not complete flow, although the patients are really cold. And of course, a huge part of it probably relates to prenatal abnormal flow in some of these patients' transpositions, hypoplasia. Their brains just aren't normal to begin with.
Right.
So to your point, and I'm the one who was pointing out some of our patients in their 40s and 50s. So I'm super glad you haven't given anybody brandy. He's suggesting we should be using scotch. That's why he drinks the scotch. That's a better strategy. But we have a patient in hospital right now who's 47 years old, has a positive teddy bear sign, and on her operative notes, there is a thing that says, Krieger has it, it says anesthetic, a nipple full of brandy, and her mom is extraordinarily clear to say that in 45 years ago, when she needed something done, that was the solution for procedures. And so she has a unbelievable fear of sharp objects. So IVs and stuff like that. So I think certainly less relevant for the patients you're taking care of because our anesthetics are so much better. But the earlier iterations of anesthesia have seemingly some tie to patients' experience that ends up impacting them, but generally more in their 40s and 50s.
Well, I do have to say, it used to be that patients would get muscle relaxant and oxygen. So, they were babies. I'm not sure how long that went on for, but we've come a long way in the anesthetic.
Yeah, no, we're counting on everybody under the age of 30 has definitely been dialed in well on the anesthetics.
So in adult disease, we use risk prediction algorithms all the time. The team you're describing is obviously very resource intensive. Have you thought about any kind of formal way to try and figure out who the highest risk in terms of these sort of neurocognitive barriers might be when they're still children, so that you can try and focus the resources and then sort of measure whether that works?
I have not, but I'm sure somebody has. And I think that's a huge part of transition and something that we should look at.
I think the thing that's sort of interesting is we do have this tremendous resource investment in kids, and frankly, they have a totally different attitude about it. April's point that there's this team, you don't ever have to sell that to a parent. Like, you don't have to prove that there's a mortality benefit to having the kid get through school successfully. But the minute they're, as Jill was mentioning, the minute they're 18, resources become extraordinarily hard to get, and their value is less obvious to an adult world. It's like, dude, suck it up and get on with it. So getting, for example, neuropsych testing. And we've done that in several of our adults, but if you hone it in and get them as adults to try to get them into vocational testing, it's been extraordinarily satisfying when we can do that, and it is an extraordinary minority that we can pull it off, because those resources aren't available. There are some programs that try really hard to identify those, but I think the risk predictor model to say, here's the continued services that are necessary for these patients, when they flagrantly have Down syndrome, everybody picks that up. When what they have is a stroke that they had when they were 20 because they chose not to take their warfarin, which is one of our patients who was and had psychosocial disaster as a child, et cetera, he ended up getting into neuropsych testing and has had, after couch surfing for 5 years, has now got a job, married, has a kid, and is totally honed in. So I think identifying those resources, but also a change in attitude from an adult care population would be super helpful.
I mean, I love that idea of the medical passport. Frankly, I feel like maybe all of our patients, regardless of their age, should have a medical passport when they've got complex conditions. But I mean, you talked about starting that at age 12, and I just wonder if can you tell at age 12 who's going to be the couch surfer who can, manage their medical issues at age 22, and would you be able to start earlier by focusing on resources?
That's a great idea. And it's like risk algorithms, and I think that would be something that we can tackle.
Yeah.
Because why not?
I'm still learning about kids at age 12.
When we did this study here a couple of years ago about early care conversations and heart failure, we found about 25% of the adults are not interested in having these conversations, and they're threatened by them. And one thing that came up in our research was that people are in particular really scared about prognostic estimates. population, do you have good models for prognosis with different kinds of procedures? And, you know, I'm naive about that, but would you use that then in one of your advanced planning conversations, or how would you use that in?
Yeah, I think I'll let Dr. Stout answer most of that because she's got way more experience than I do. But I think in general, I think we have less prognostic information about a lot of these individual kids or adults and how they'll do, because what little research there is out there has kind of lumped everybody together. And we know that the spectrum of disease and repair and physiology after all of that is really wide in ACHD, and maybe even a little bit more so than in adult acquired heart failure. And a lot of these adolescents and adults do ask for prognostic information, and I think we're less able to give it to them.
I will add nothing to that except that the other thing I've seen is how egregiously wrong I can be about, for anybody who ever took care of Jason Sinclair. I spent like 8 years telling him the end was near soon. Like, first met him, this is not going to go well. 2 years later, he's still around, he's still doing the same old, no. So I went on like literally 10 years of telling him the end is nigh, and I was wrong. Eventually, that was not the case, but I think lacking good predictive algorithms on both directions, who's going to be fine and who's going to struggle, we assume a lot because we see some folks not doing well, but I think we're also not necessarily particularly correct on mortality, even in the sickest of patients, until it's really that top 1% of sick patients. So Jill's right, we don't have good predictors just yet. Oh, and we are out of time.
Okay.
So thanks, everyone. Thanks so much, Jill, for blazing new ground.